Welcome. Today I shall discuss about the salient points of iron deficiency anemia. Clinical features of anemia: fatigue, paleness, yellow skin in hemolytic anemia, dark urine in hemolytic anemia, shortness of breath, dizziness, cold extremities, palpitation, angina chest pain, sore tongue, cognitive disturbance, memory loss, confusion. Physical finding: pallor, jaundice in hemolytic anemia, glossitis, tachycardia, soft systolic murmur, splenomegaly in case of hemolytic anemia, petechiae purpurae ecchymosis in aplastic anemia, diminished muscle power. This is the slide showing different sites for detection of the pallor. So here you see it is the lower palpebral conjunctiva, it's the tongue, nail bed, palmar region, especially the palmar creases. In this side, we see the glossitis, angular cheilitis, koilonychia, spoon-shaped nail. Here, the three pictures showing the koilonychia, iron deficiency anemia is characteristic. In this slide, we see different stages of development of RBC from the bone marrow. In the primary stage, it is the hemocytoblast, hematopoietic stem cell. It's further going to develop erythroblast in early stage, late stage, normoblast, an exclusion of the nucleus forming the reticulocyte, and finally the erythrocyte. Before understanding of case of anemia, we have to know about the reticulocyte count. As we have seen in the previous slide, that reticulocyte is being formed from the hematopoietic stem cell, the process of early erythroblast, late erythroblast, normoblast, and finally the reticulocyte. Reticulocyte, after being formed in the bone marrow, is coming into the circulation as premature RBC. This reticulocyte is 0.5 to 2% of the total RBC count. But for actual calculation of the anemia patient and for anemia classification, it is better to depend upon the reticulocyte production index. How to calculate? Reticulocyte production index, that is RPI, is calculated as reticulocyte count of the patient into ratio of hemoglobin percent divided by 15 and 2. So, in stable state, the reticulocyte production index is 1. But when it is anemia, bone marrow is in the hyperactive stage, it is usually 2 or more. So it is better to depend upon the reticulocyte production instead of reticulocyte count. Come to the laboratory test for anemia diagnosis. First is the CBC or complete blood count. Under this heading, it is RBC profile, RBC index, RBC morphology, WBC profile, and platelet count. Under the heading of RBC profile, it is total RBC count, hemoglobin, hematocrit, reticulocyte count. Under the heading of RBC index, it is the mean corpuscular volume, mean corpuscular hemoglobin, mean corpuscular hemoglobin concentration, red cell distribution with RBC morphology, WBC profile. Under the heading, it is WBC count and WBC differential count and platelet count. Next, come to the body iron profile. Under this heading, it is the serum ferritin, serum iron, and total iron binding capacity. Next is the serum vitamin B12 and folic acid estimation, marrow examination, it is marrow aspirate and marrow biopsy. Some salient points regarding the anemia diagnosis. As per WHO, when the hemoglobin percentage is less than 13 gram per deciliter in male and 12 gram in female, it is anemia. When hemoglobin percentage is less than 8 in male and less than 7 gram per dl in female, it is severe anemia. Mean corpuscular volume determines the RBC cell size. When it is more than 100 femtoliter, it is macrocytic RBC, but when it is less than 80, it is microcytic RBC. Mean corpuscular hemoglobin and mean corpuscular hemoglobin concentration determines the hypochromic RBC. Red cell distribution width determines the variation in the RBC size and it should be less than 14.5%. Now come to the anemia classification. As I have discussed in the earlier slide, we have to depend upon the reticulocyte production index for anemia classification. RPI less than 2, RPI more than 2 or 2. First, we will discuss the RPI less than 2. Normally in anemia, the RPI should be 2 or more as per normal marrow response to the anemia. But when it is less than 2, we can say the marrow is non-hyperproliferative. It is non-hyperproliferative marrow response. Under this setting, it is the deficiency of the nutrient, that is iron deficiency, cobalamin deficiency and folic acid deficiency. Number 2 is the erythropoietin insufficiency, as in chronic kidney disease, chronic inflammation, cancer, etc. Number 3, it is the marrow insufficiency, as is myelofibrosis, aplastic anemia, myelofibrosis, like this. What is the RBC pattern? In the iron deficiency, it is normocytic normochromic anemia, RBC, in the early iron deficiency, but in the advanced iron deficiency, it is microcytic hypochromic RBC. In cobalamin and folate deficiency, it is the macrocytic RBC. Now come to the erythropoietin insufficiency, it is the normocytic normochromic RBC. In marrow insufficiency, it is normocytic normochromic RBC. Now come to the RPI 2 or more. This is the hyperproliferative marrow response. Under this setting, two important items, chronic hemorrhage and hemolysis. What is the RBC pattern? Chronic hemorrhage, it is microcytic hypochromic RBC. It is like the picture of severe iron deficiency pattern. Under the hemolysis, there are so many items under hemolysis like hemoglobinopathy. Under the hemoglobinopathy, it is thalassemia, sickle cell anemia. Similarly, it is enzymopathy like G6PD deficiency, membranopathy like hereditary spherocytosis, electrocytosis, paroxysmal nocturnal hemoglobinuria, hemolytic uremic syndrome, microangiopathic hemolytic anemia, autoimmune hemolytic anemia, toxin, and so on. And what is the RBC pattern? Usually it is normocytic normochromic, but in case of thalassemia, it is hypochromic microcytic RBC. So, if we see a picture of hypochromic microcytic RBC, we have to think three things. Maybe case of severe iron deficiency, it may be case of chronic hemorrhage, it may be case of thalassemia. So we have to depend upon the ferritin, serum ferritin level for detection of the severe iron deficiency or chronic hemorrhage, and for thalassemia or confirmation is to be done by hemoglobin electrophoresis. Distribution of anemia. Iron deficiency anemia, commonest. 50 to 60% of the total. Next common is the chronic disease including CKD and inflammatory anemia 25 to 30%, vitamin B12 and folic acid deficiency anemia 5 to 10%, hemolytic anemia 1 to 3%, marrow failure anemia 1 to 2%. Let us discuss the salient points regarding iron deficiency anemia. Daily need of elemental iron for adult male is 10 mg and for the adult female it is 15 mg, of which only 10% is absorbed. Iron absorption largely occurs in the duodenum and jejunum. Iron-rich food, heme iron, animal waste, meat, liver, poultry like chicken, fish like salmon, sardine, non-heme iron, plant waste, dark leafy greens, spinach, kale, legumes like lentil, chickpeas, beans, nuts, dried fruit like apricots, raisin. Phytate and phosphate present in the vegetarian foodstuff reduces the iron absorption by 50%. Iron status marker number 1 the serum ferritin which replaces the body iron store. Number 2 serum iron. 3 total iron binding capacity that is TIBC. 4 is the transferrin saturation. Diagnosis of iron deficiency anemia. Anemia usually mild to severe. MCV normal to low, low means less than 80 pentoliter. MCH normal to low, low means less than 27 picogram. MCHC normal to low, where low is less than 30 gram per deciliter. Serum ferritin usually less than 15 microgram per liter. If it is less than 30, it indicates iron deficiency, but when it is less than 15, it is a specific indicator. Total iron binding capacity more than 360 microgram per deciliter. Red cell distribution with more than 14.5%. Regarding RBC morphology, in the early stage of iron deficiency, it is normocytic normochromic. But in the advanced stage, it is microcytic hypochromic RBC with anisocytosis, that is variable size, and poikilocytosis, that is variable shape. Here is the picture of anisocytosis, variable sizes of RBC, poikilocytosis, variable shape of RBC. Stages of iron deficiency anemia. Stage 1, that is negative iron balance. And in this stage, there is no anemia. There is starting of depletion of body iron store. The serum ferritin is decreased, that is less than 20 microgram per liter. TIBC is increased. Serum iron low, transferrin saturation normal. RBC normocytic and normochromic. Come to the stage 2, that is iron deficient erythropoiesis. Still there is no anemia. Serum ferritin is decreased, TIBC increased, serum iron low, transferrin saturation low. RBC normocytic normochromic. Come to the stage 3. This is the stage of anemia. Iron deficiency anemia starts here. Serum ferritin is decreased, TIBC increased, serum iron low, transferrin saturation low. In the early stage, RBC is normocytic normochromic. In the advanced stage, it is microcytic hypochromic RBC. Now come to the causes of iron deficiency. Decreased supply of iron, increased demand of iron, excessive loss of iron. First come to the decreased supply of iron, like inadequate diet, malabsorption, like tropical sprue, Crohn's disease, gastric surgery, acute or chronic inflammation. Decreased demand, infancy and adolescence, pregnancy, erythropoietin therapy. Regarding excessive loss, example, chronic blood loss, menstrual excess blood loss, acute blood loss. Now come to the treatment of iron deficiency. First is the oral iron therapy. What are the criteria? Preferred for mild to moderate deficiency, 150 to 200 milligram elemental iron daily in 2 to 3 divided doses. Duration of treatment is 3 to 6 months for anemia correction, although it depends upon the deficiency. Once the anemia is corrected, treatment should be continued for another 6 months to fill the iron store. Ideally should be taken in empty stomach as food interfere absorption. Nausea and constipation are the common side effect. Common iron salt with corresponding elemental iron are ferrous sulfate 325 mg, elemental iron 65 mg, ferrous fumarate 325 mg, elemental iron 107 mg, ferrous gluconate 325 mg, corresponding elemental iron 39 mg. Come to the parenteral iron therapy. Indication for intravenous iron therapy. Unable to tolerate oral iron, needs are relatively acute, need iron on an ongoing basis as in persistent gastrointestinal or menstrual heavy loss. During erythropoietin therapy, where a large demand of iron is produced. What is the requirement? It can be easily be calculated with the help of the formula body weight in kg multiply with the constant factor 2.3 into 15 minus patient hemoglobin in grams per deciliter plus 500 to 1000 milligram extra iron for store replacement. Common parenteral iron preparation with corresponding elemental iron per infusion. Ferrumoxitol, elemental iron 510 milligram, ferric carboxymaltose, elemental iron 750 milligram, iron sucrose, elemental iron 200 milligram. 500 to 1000 milligram of elemental iron is given in 1 to 2 sessions in a week. Side effects: arthralgia, skin rash, low grade fever, rarely anaphylaxis. Red cell transfusion preferred for severe anemia, that is hemoglobin 7 to 8 gram per dl, cardiovascular instability having shortness of breath, tachycardia, extreme weakness, continued and excessive blood loss. These are the indications. 1 unit of packed cell transfusion can raise the hemoglobin up to 1 gram per deciliter. Thank you to all.